it sounds like there are aliens in the trees down there, and they are just disgusting. They're shells to walk on. So another reason to be happy to be in Maine with this beautiful weather. So just to tell you a little bit about Dr. ANWAR, he joined our Pediatric Hospital Medicine Division as an assistant professor at Tufts about a year ago, and we're so glad that he joined us. He completed his undergraduate degree, which I think was actually a combined undergraduate medical school program that was accelerated, but he received a bachelor's degree in psychology with distinction, and then graduated from the University of Virginia Medical School in Charlottesville. He pursued residency at the Children's Hospital of Richmond at Virginia Commonwealth University, and completed residency in 2015, and then stayed on as chief resident from 2015 to 2016. After completing his chief residency, he continued to work as an assistant professor on the faculty within the PHM division at VCU. And he took advantage of every opportunity he could to get additional training in medical education, which I think is his passion. So that consisted of getting a certificate from the VCU School of Education in medical education, and then joining the APPD Leadership and Educational Academic Development Program. He completed a research certificate in medical education from the Association of American Medical Colleges, and also completed the APEX, or Advancing Pediatric Educator Excellence Teaching Program, sponsored by the AAP and the APA. He has received numerous teaching awards in his relatively brief career, and has, in terms of has had several regional and national presentations on a variety of topics, including family-centered rounds and medical student perceptions, use of the pediatric early warning system scale, refractory Kawasaki's disease, interprofessional education, and other topics. So after refreshing reading through Dr. ANWAR's CV, I need to set up a meeting with him to see what projects he wants to work on this year. So, but very grateful that he's going to talk to us today about nutritional rehab of patients hospitalized for anorexia nervosa.
Thank you very much, Dr. Ottolini. So yeah, I've been here since August. It's been wonderful. If I haven't met you, I hope to do so soon. I truly can't see anything about the number of participants, so hopefully there's somebody here. And I guess one way that I will be able to figure that out is that I'm going to try to use some real-time online polling during this presentation. Oh, there it is, 67 people. All right. And so if it's not working, I'll just not try to do it. But basically, if you, there we go, no conflicts of interest. Here is the CME code. And then here are learning objectives. We'll hopefully be able to list admission criteria, diagnose refeeding syndrome, compare the efficacy and safety of different refeeding methods, and create a safe refeeding plan for patients admitted with anorexia nervosa. So if you are able to, please text HADI ANWAR 427, it's not case sensitive, to the number 37607. I do think there's probably a limit to the number of respondents. So if you try to respond and you're not able to, I'm sorry about that. And feel free to use the chat if you want to answer any of the poll questions there. And so let's just do a quick trial question to see how this works. It would also be great for me to know who, this is not the right one, who is in the audience. So let's see if we can get this to work. Hey, how did it open? I don't know where it went. Okay. All right, so if you have texted HADI ANWAR 427 to that number 37607, hopefully you will be able to answer this question. It looks like we're getting some responses. Let me see how I make this bigger. The question is just asking, what is your role? And I will figure out how to make this larger. That's not right. There we go. All right. So I'm glad to see that we have a few members from some different disciplines that are clearly very involved in the care of patients with anorexia nervosa. All right, poll is full. So hopefully a decent representative sample of who's here. Great to know. All right. So anorexia nervosa, or AN, is one of the most common chronic illnesses of adolescents, affecting about 0.5% of adolescents. Over the past decade, I feel like I've been seeing more and more patients admitted to the hospital for anorexia nervosa and with more severe illness, especially since the pandemic. And the National Eating Disorders Hotline has reported their call volume has increased significantly recently. Some eating disorder facilities have reported increased volumes as well. And a recent study found that 60% of respondents with anorexia nervosa reported worsening illness during the pandemic. I felt like I noticed significant variations in practice in the inpatient setting, and this grand rounds was a great opportunity for me to see if I could find evidence-based medicine to inform some of the clinical questions about the care of patients with anorexia nervosa. So the DSM-5 updated the diagnostic criteria for anorexia nervosa in their most recent rendition. Patients must meet the following three criteria. First, they restrict their caloric intake relative to their energy requirements, resulting in significantly low body weight. Second, they have an intense fear of gaining weight or behaviors that consistently interfere with weight gain. And third, they have altered perceptions of their body weight or shape. Their body weight or shape excessively influences their self-value, or they persistently lack acknowledgement of the seriousness of their low body weight. In atypical anorexia nervosa, diminished self-worth, nutritional restriction, and weight loss mirror that seen with anorexia nervosa, but body weight and presentation is in the normal or above normal range. So anorexia nervosa is primarily managed in the outpatient setting, and the current preferred method of treatment is family-based therapy. However, about 45% of patients with anorexia nervosa will require medical stabilization in a hospital setting at some point during their illness. And this illness carries a mortality rate of 2 to 8%, primarily due to cardiovascular complications and suicide. The goal of admission is to safely restore medical stability via nutritional rehabilitation and weight restoration. And so the Society for Adolescent Health and Medicine created the following admission criteria in a 2015 position paper. And so first, for patients that are significantly underweight, they defined this as patients that are less than 75% of the median BMI for age and sex using the CDC growth charts. And so median BMI or MBMI is essentially, so for example, if you had a 16-year-old female, the median BMI or the 50th percentile BMI would be 20. And so if she had a BMI of 15, she would be at 75% of the median BMI. And so this is a measure of malnutrition. For electrolyte disturbances, this includes hypokalemia, hyponatremia, hypophosphatemia, metabolic acidosis or metabolic alkalosis. EKG abnormalities can include prolonged QTC or severe bradycardia. Acute medical complications of malnutrition can include syncope, seizures, cardiac failure, pancreatitis, a number of others. Failure of outpatient treatment can be due to comorbid psychiatric or medical conditions that prohibit or limit the appropriate outpatient treatment. And this can include things like severe depression, suicidal ideation. But for medical treatments, type 1 diabetes, for example, and misusing insulin to create weight loss, or inadequate social support or follow-up can also contribute to failure of outpatient treatment. And then physiologic instability. And so how is that defined? So that includes severe bradycardia, which is often defined as a heart rate of less than 50 beats per minute during the daytime or less than 45 beats per minute at night. Hypotension of less than 90/45, or hypotension for age if they're on the younger side. Hypothermia would be a body temperature of less than 35.6 degrees Celsius, and orthostasis, so either an orthostatic increase in pulse greater than 20 or a decrease in systolic blood pressure of greater than 20, or for diastolic blood pressure of greater than 10. So the recommended approach for decades was to start low with calories and go slow in advancement. And this was due to the concern for refeeding syndrome, which was initially recognized after reports of World War II prisoners of wars that died during refeeding after having been starved. It was thought that refeeding syndrome occurred in these prisoners of war who were refeeding too quickly. The pathophysiology of refeeding syndrome is incompletely understood, but the proposed mechanism is that total body stores of electrolytes like phosphorus are depleted from starvation, even if serum concentrations are normal, which they can be because if the kidneys are increasing resorption, or there's increased resorption from the bones. And then dehydration and extravasation of fluid into the interstitial space can also contribute to concentrating the serum concentrations, even if the total body stores are low. The body switches from primarily carb metabolism to fat and protein metabolism during starvation. And fatty acid oxidation does not require phosphorus intermediates, and so phosphorus is utilized less during starvation. Refeeding, especially the introduction of carbs, results in an insulin surge, which results in electrolytes shifting intracellularly to create phosphorylated metabolites like ATP. The subsequent electrolyte derangements, especially hypophosphatemia, but also hypokalemia and hypomagnesemia, result in multi-organ dysfunction, including heart failure, ventricular arrhythmias, and delirium. Refeeding starved patients may also cause fluid and sodium retention, likely related at least in part to insulin secretion, and then this can lead to peripheral edema or even circulatory overload, which can contribute to multi-organ dysfunction. So there is no consensus on diagnostic criteria for refeeding syndrome. Here's one example of diagnostic criteria published in a 2016 study on adults and then used in 2 additional studies. The patient must have severely low electrolytes, which in the study was defined as a phosphorus of less than 1, a potassium of less than 2.5, or a magnesium of less than 1.2. Secondly, they must have peripheral edema or acute circulatory fluid overload. And third, they must have signs of multi-organ dysfunction, such as pulmonary edema, respiratory failure, cardiac failure, delirium, or coma. So there are case reports of refeeding syndrome in adolescents with anorexia nervosa. You can see that they frequently presented with delirium and or cardiovascular compromise. Some case reports described severely malnourished patients who already had medical complications on admission that worsened with the initiation of refeeding syndrome. For example, the 14-year-old female with an admission weight of 28 kilograms had peripheral edema, mild transaminitis, and thrombocytopenia on admission, and then developed worsening circulatory overload, liver dysfunction, and DIC during refeeding. Literature reviews have reported finding over 20 case reports of refeeding syndrome in anorexia nervosa. And I think that might actually be an overestimate based on the diagnostic criteria in the previous slide, because in reading some of the case reports and abstracts, it seems like some patients were labeled as having refeeding syndrome who only had a pretty significant or severe hypophosphatemia, but without any mention of organ dysfunction. So due to the concern for refeeding syndrome, the 2006 American Psychiatric Association consensus-based guidelines recommended starting at 30 to 40 kcals per kilo per day, which usually would come out to somewhere between 1,000 to 1,600 calories per day, targeting an average weight gain of 2 to 3 pounds per week. They also suggested potentially starting even as low as 600 kilocalories per day for patients who had been consuming very few calories prior to admission. So if they'd been consuming 300, 400, 500 calories a day, then just starting a little bit above that. So start low and go slow was the mantra for refeeding patients for decades. But starting around the late 2000s, this mantra begins to be challenged. The management of really sick patients with anorexia nervosa, abbreviated as marzipan, working group from the United Kingdom in 2010 published a anecdote of a 20-year-old female who was admitted with a BMI of 13 and started on 200 calories per day and died 5 days after admission. They attributed this to overcautious refeeding and coined, or at least popularized, the term underfeeding syndrome. And then in their 2012 junior marzipan report for patients under 18, they noted that an overcautious approach can be counterproductive in an illness that welcomes any opportunity to minimize even very low intakes. This report also recognized that almost of greater importance than the starting energy intake is the rate of increase, because it's as a result of prolonged low intake that underfeeding occurs. So there is no consensus on the most appropriate rate of increase, but a common recommendation at the time was to increase daily from baseline intake by 200 calories per day if phosphate levels are not dropping significantly. The concerns about underfeeding syndrome were supported by a 2012 article from Garber. So there was 35 patients who were started on an average of 1,200 kilocalories per day, which came out to 28 kilocalories per kilo per day. And the caloric goal was increased by about 200 kilocalories every other day. They found that 83% of patients initially lost weight. You can see that on day 2 and 3, they had lost a significant amount of weight compared to their admission weight. And then they found that weight loss peaked after 3 days, and there was not significant weight gain compared to the admission weight until day 8. So starting where the stars are, where the average prescribed diet had increased from about 1,200 to almost 2,000 calories per day. These findings mirrored the initial weight loss seen in a 1994 study in which 53 patients were started from 1,000 to 1,200 calories per day, and then initially lost weight prior to eventually gaining weight. We also get the first couple of studies using higher calorie refeeding, which will be abbreviated as HCR, as opposed to lower calorie refeeding or LCR. So the first few studies of higher calorie refeeding are coming out in the late 2000s. 2 different researchers reported commencing refeeding at 1,900 or 2,000 calories per day in over 600 patients total, and had no cases of refeeding syndrome. So people start to wonder if starting low and going slow is the best way. So in trying to determine an ideal regimen for nutritional rehabilitation, what outcomes would we try to optimize? And let's see if this poll everywhere works again. All right. So what factors would the ideal refeeding protocol try to optimize? And this is just a word cloud, so you can just type in whatever your answer is. And if you haven't joined or try to join, you can text HADI ANWAR 427 to this number here. But what would you want a refeeding protocol to perform well at doing? All right. I'm not sure if, oh, I have to activate it. Thank you. That was, all right. Sorry if you were trying to type in anything and it wasn't activated. So definitely want kind of good outcomes related to weight, to safety. And part of safety is going to be electrolyte monitoring, acceptable to the patient. Let's see. Awesome. Stabilization. Great. GI wise, so probably like low complications, etc. All right. So in terms of measuring measures of efficacy of refeeding methods, first you want patients to actually be able to adhere to the treatment that you're going to prescribe. And then faster weight gain is important. And why is that? So weight restoration is the treatment for the physiologic complications of anorexia nervosa. And so faster weight gain should hasten physiologic recovery. Faster medical stabilization should also shorten length of stay. And this is, always important from a cost and flow standpoint. But for patients with anorexia nervosa, it's important to recognize that they often are not getting much in the way of mental health services while hospitalized. And one study found that core pathologic beliefs in anorexia nervosa patients are not modified during hospitalization. Shortening the length of stay may mean that they can start a more efficacious therapy sooner, like the family-based therapy that's currently the kind of highest standard for treating anorexia nervosa. Faster weight gain may also improve long-term outcomes. So a 2004 study found that patients gaining at least 1 kilo per week in the hospital were less likely to be readmitted within a year of discharge. And another found that the threshold was 0.8 kilos per week, and that they had a lower incidence of deterioration after a year. So it's possible that that faster weight gain may also improve long-term outcomes. Then, definitely want to have some balancing measures. So you want it to be a safe. We don't want to increase the risk of refeeding syndrome. We also don't want to increase readmissions. For example, like patients are being discharged so quickly that they are not ready to continue their prescribed diets that they were getting in a more structured setting in the hospital. Patient satisfaction would be a nice measure. I did not find any research about this related to caloric prescription. And generally, caloric intake is not discussed with patients with anorexia nervosa in the hospital. So I think it would be a difficult measure to obtain. And then long-term prognosis in terms of weight maintenance, clinical remission of disease, and readmissions. So let's see how higher calorie refeeding compares to lower calorie refeeding on these measures, starting with adherence. So there's no consensus on the definition of HCR or high calorie refeeding, but generally this is referring to initial diets of 1,400 calories per day or more. And higher calorie feeding methods vary across studies, but in the United States, most commonly emphasize a meals-based approach, so getting patients to eat by mouth. Patients with anorexia nervosa are restricting calories, and so are they actually able to consume the calories that are prescribed in a higher calorie refeeding protocol? So this 2013 study initially prescribed patients to take 1,500 calories, and then they were increased by 250 calories about every other day until they reached their goal of 2,500 calories. And they found that the average actual intake for patients exceeded the prescribed intake until they got to the very maximal level where it was still 98% of what they prescribed. So demonstrated pretty good adherence to being able to take the prescribed amount of calories. And then a 2013 study compared cohorts that, so initially at the institution, they were using lower calorie refeeding, and then they had made a practice switch at their institution to higher calorie refeeding. And so they compared those two cohorts and found no difference in the percentage of patients who ever relied on supplemental drinks like Booster, Ensure, or whatever they used, or the number of calories that the different groups were coming from supplemental drinks. So whether they were doing lower calorie feeding or higher calorie feeding, the same percentage of patients were able to complete their meals. And then the STRONG trial in 2021, which I'm going to be coming back to periodically because it's the kind of best randomized control and only randomized control trial that we have of comparing outcomes for LCR and HCR. So they found that that 94% of the over 6,000 meals in the study were within 200 calories of the prescribed number of calories. And anytime that the actual intake deviated by more than 200 calories from what was prescribed, it was always in the lower calorie group, and always that they were taking more than 200 calories than what they'd been prescribed. So always taking more, not less. So now that we know that patients are able to, consume the amount of calories that are being prescribed, whether it's lower calorie refeeding or higher calorie refeeding, let's see how caloric consumption affects weight restoration. So in 2007, we have an article that reported an average weight gain of 2 kilos per week for 300 patients that were started on 2,000 calories per day. And then in 2015, we have another study that started even higher at 2,400 calories and reported, again, high weight gain. Another study that started at 2,600 calories per day on average, and again, saw a 2 kilo per week weight gain. There's no comparison group in any of these studies, but if you recall, the APA guidelines were suggesting a average weight gain of about 1 kilo per week. So these are definitely higher than kind of what was recommended in the 2006 APA guidelines. So then we have the first study that compared a lower calorie refeeding group to a higher calorie refeeding group. And this was a quasi-experimental study. It's the same study that I referred to where they used to use LCR and then they had a practice change with their institution and with the HCR. So they're comparing these two cohorts. So this blue line should look familiar. It's the one that showed that with lower calorie feeding, initially there was weight loss prior to beginning weight gain. And so in this group, they were started around 1,100 calories, while in the higher calorie refeeding group, they were started around 1,800 calories. They were also advanced slightly faster in this higher calorie group in terms of the number of calories per day that they were taking. So unlike the lower calorie group who initially lost weight, the HCR group immediately started to gain weight. The weight gain was nearly double for this group, and it had significantly been increased from admission weight by day 4, whereas for the lower group, it wasn't until day 8 that they had gained a significant amount of weight over their admission weight. So by 2015, there's a position paper from the Society for Adolescent Health and Medicine that supports HCR and a goal weight gain of 1 to 2 kilos per week. So studies are suggesting that there's faster weight gain with HCR. 2016 systematic review found that from 2010 to 2015, 85% of studies were using HCR protocols, but they were primarily retrospective studies and mostly without comparison groups. But in the last year, we was published the multi-site randomized control trial, or which is abbreviated as the STRONG trial, comparing lower calorie feeding to higher calorie feeding in patients who are 12 to 24 years old. So 51 patients received LCR and 60 patients received HCR. The LCR group started at 1,400 kcals and they were increased by 200 kcals every other day. And the 60 patients in the HCR group were started at 2,000 calories per day, and they were increased every day instead of every other day by 200 calories. And clearly they gained significantly more weight at a faster rate. And so we are seeing faster weight gain with higher calorie feeding. So are we also seeing physiologic stability, an earlier physiologic recovery with higher calories? And so the same STRONG trial also evaluated how quickly patients had physiologic recovery, and they defined this as that for a 24-hour period, the patient had to meet all of the following criteria. So heart rate criteria, systolic blood pressure, normothermia, orthostatic increase in heart rate less than 35, and an orthostatic decrease in systolic blood pressure less than 20. And then they had to have achieved at least 75% of the median BMI for their age and sex. So these criteria represent the resolution of the admission criteria that I had shared earlier from the Society of Adolescent Health and Medicine, except for there was some more leniency in orthostatic heart rate, since there was evidence to suggest that this can take 3 or more weeks to resolve in patients with anorexia nervosa, even as they're gaining weight. So you can see here that the data suggests that the HCR group did have a faster return to medical stability by about 3 days. And so then what about length of stay? There was a couple of studies in 2013 that compared cohorts of patients who had either received lower calorie feeding or high calorie feeding. And, this study showed a 3.5 day faster, a shorter length of stay. And this one was a 5 day one. And the strong trial looked at length of stay as well and found a 4 day shorter length of stay with higher calorie refeeding. And then the strong trial also evaluated cost and determined that it was less expensive, most likely because it was a shorter length of stay. Inpatient admission is the most expensive treatment modality for anorexia nervosa, and so shortening length of stay would, could be expected to significantly reduce cost. So overall, it seems like HCR is an improvement to the standard of care for anorexia nervosa, but is it safe? None of the HCR studies reported any patients going into refeeding syndrome. The issue is that refeeding syndrome is very rare, and these studies don't have a sufficiently large sample size to be powered enough to detect such a rare complication. So instead, a proxy measure is used to determine risk of developing refeeding syndrome. And that proxy measure is hypophosphatemia, which is considered the hallmark biochemical finding in refeeding syndrome. So the first question is, what is the time frame for development of refeeding hypophosphatemia? A 2003 chart review of 69 adolescents found 81% of patients had their phosphorus nadir in the first week. And then additionally, in a chart review of 22 severely malnourished young adults, the 10 patients who developed refeeding hypophosphatemia all developed it by day 6. So it seems like the first week is the highest risk period. And so the Journal of the Society of Adolescent Health and Medicine publishes a position paper on refeeding hypophosphatemia that recommends monitoring phosphorus every 24 to 48 hours during the first week of refeeding. But that said, there are no strong evidence-based guidelines for lab monitoring during refeeding. And as expected, varying monitoring schedules are used both in practice and in research. So are patients receiving higher calorie refeeding at higher risk for hypophosphatemia? There was a study in 2013 that had lower calorie and higher calorie refeeding cohorts and noted a similar incidence of refeeding hypophosphatemia, as well as a similar lowest phosphorus in patients. And then we have 2 additional studies, including the STRONG trial, which randomized patients to LCR, HCR, all showing that the initial caloric prescription, so whether they're getting lower or higher calories initially, is not predicting patients that are going to have refeeding hypophosphatemia. What actually seems to be predicting hypophosphatemia is the severity of malnutrition. So in 2003 was the kind of first study to demonstrate that phosphorus nadirs during refeeding were directly proportional to severity of malnutrition. They used percent ideal body weight as their measure of nutritional status. And so you can see kind of a clear direct association between being more malnourished and having a lower phosphorus value. And this was replicated in a 2010 study where, again, they noted that the lower the percent of the further they were from ideal body weight, the lower their phosphorus values. And this finding has been replicated in at least 4 more studies since then, all noting the relation between severity of malnutrition and hypophosphatemia. So it's not surprising that the most malnourished patients are at higher risk for hypophosphatemia. And it's not caloric prescription that is increasing the risk of hypophosphatemia. You may remember the case report that I described earlier, that the admitted patients were started anywhere from 500 to 1200 calories, which would all be considered lower calorie refeeding. And they all still developed refeeding syndrome. So it wasn't being triggered by higher calories. So do we have any guidance on how to care for the most severely malnourished patients? And so what is the definition of severe malnutrition? The Society for Adolescent Health and Medicine, they suggested using being less than 70% of the median BMI for age and sex, which is what is commonly used by researchers. Studies, unfortunately, will vary by either presenting percent ideal body weight or median BMI or just BMI. And so there are kind of other definitions as well that were suggested. So BMI less than 15 also could be an acceptable definition. Not many studies look at refeeding severely malnourished patients. There was a 2012 chart review that was done of 22 young adults with an average age of 26 who were admitted with an average BMI of 13. All of them had a BMI less than 15, and they were initially started on 1,000 calories per day. There was 10 patients in that study that developed refeeding hypophosphatemia and 12 that didn't. And they were started on similar number of calories. So it wasn't, so the amount of calories they were on was not associated with their development of hypophosphatemia. Then in 2013, we have this study that had a subsample of severely malnourished patients. And so 31 of the severely malnourished patients had received higher calorie feeding, while 18 of the more severely malnourished patients had received lower calorie feeding. They did not have a significant difference. They found similar rates of hypophosphatemia in the two studies, but it was notable that these patients were not randomized by any means, and the severely malnourished patients who received lower calorie feeding had a more significant weight loss prior to admission. So even though they're all considered severely malnourished, maybe this group was even more severely malnourished. And that's why they seem to have maybe more hypophosphatemia, but in general, it was not determined that caloric prescription, even in this subsample of severely malnourished patients, was associated with refeeding hypophosphatemia. And then there is a 2006 systematic review of refeeding approaches that concluded that there was insufficient evidence at the time to support deviating from the historical management of the most severely malnourished patients, which was lower calorie feeding. The AAP published a clinical report on anorexia nervosa just this year, and they also suggested more careful refeeding for patients who are less than the 70th percent of median BMI. The STRONG trial also came out recently, and they did have inclusion criteria down to 60% of median BMI, but they didn't share how many patients they actually had that were severely malnourished. So it would be hard to, draw conclusions from that, since we don't have a sample size of how many patients they actually had that were severely malnourished. So it's essentially been concluded by a variety of organizations that right now there's insufficient evidence to really guide what's the best choice for severely malnourished patients. All that said, lower calorie feeding is not reducing the risk of hypophosphatemia. And so are there other things that we can do to potentially reduce that risk? One idea, has been routine phosphate supplementation. Does that reduce the risk of repeating hypophosphatemia? And so there was a 2013 review that found that the average incidence across studies of hypophosphatemia was 14% in patients being refed, but there was a really wide variation in refeeding hypophosphatemia. So the most of the studies that I looked at did not routinely prophylax with phosphate supplementation. So here's kind of a collection of the incidents found in those studies. 1 second, I'm so sorry. Okay. So in all of these studies, there was no routine phosphate prophylaxis. And so overall, there was a total number of almost 800 patients in these various studies. By no means was this a systematic review on my part, just of the studies that I saw that reported this. I kind of just tabulated what their data was. And so more than 25% of the patients in these studies that did not prophylax with phosphate as part of their protocol. Over 25% of them had refeeding hypophosphatemia. There were a few studies that did prophylax all patients starting on admission with phosphorus, and they had a less than 2% incidence of refeeding hypophosphatemia. And then only one of those studies reported any kind of safety issue related to giving phosphorus. They, in this study right here, there were 11 cases of hyperphosphatemia, but none of those was clinically significant or required any sort of intervention. So, so does supplementation reduce the risk of hypophosphatemia? Probably, it seems like there's probably evidence to suggest that it may, but there has not been any study that randomized patients to get supplements or not, as far as I'm aware. Is it helpful to reduce kind of this amount of hypophosphatemia? Most studies did not include routine supplementation, and they just managed refeeding hypophosphatemia with repletion as needed, and they didn't have any cases of refeeding syndrome. So it doesn't really seem to be, changing the incidence of this. But again, refeeding syndrome is so rare that you would really need a very large sample size to detect kind of anything that would reduce the incidence of refeeding syndrome. Since the most severely malnourished patients are going to be at highest risk for refeeding syndrome, maybe it is worth reducing their risk of refeeding hypophosphatemia from the get-go as much as possible. Also, there's the possibility that clinicians may, or even protocols may suggest not increasing calories when there's hypophosphatemia. And so if supplementation does reduce hypophosphatemia, then hypothetically they would advance their calories faster and improve faster and maybe have a shorter length of stay, and kind of stay on track with the protocol. Is it safe? Probably, although it really hasn't been studied much. And is it worth the cost or even just the effort of having one more thing that the patient has to do? It's unclear. But overall, higher calorie refeeding does seem safe and patients are leaving the hospital faster. But is it affecting long-term outcomes? You may remember that I mentioned 2 studies that found that faster weight gain may protect from readmission. And since patients with higher calorie feeding definitely seem to gain weight faster, are we seeing less readmissions? Or if they're being discharged too quickly, are we seeing more readmissions? So the STRONG trial, again, randomized patients to receive LCR or HCR and followed those patients for a year. About 1/3 of patients in each group were rehospitalized during 1-year follow-up, and there was no difference in the number of times that they were hospitalized or the number of days that they were rehospitalized. Weight maintenance was similar in both groups, as you can see here. The confidence intervals are overlapping at all the periods at which they followed up. And we know that eating is obviously distressing to patients with anorexia nervosa. And even if studies are intended to be blinded and patients don't explicitly know that they're receiving higher calorie feeding, they're often adept at determining the caloric content of foods and knowing how much calories is in different foods. So is there the potential that higher calorie feeding might hamper their psychological recovery, since they know that they're eating more than, or they may be able to tell that how many calories they're eating? The STRONG trial used the eating disorder examination questionnaire to assess psychological recovery, and the LCR and HCR groups had similar results at 1 year. And so they defined remission as both weight maintenance as well as improvement in psychological outcomes, like the as measured by that eating disorder questionnaire. And they found similar rates of remission with LCR and HCR. So let's summarize the research on higher calorie refeeding. We can't definitively say that there's no increased risk of refeeding syndrome with higher calorie refeeding, given the very low incidence of refeeding syndrome. But current research suggests it is safe for most patients with close monitoring and electrolyte correction. There's no evidence it changes long-term outcomes, but it does result in a shorter admission with faster weight restoration and faster medical stabilization. Since the majority of hospitalized patients have mild to moderate malnutrition, they should receive HCR. and we're still determining how best to refeed the most severely malnourished patients. And most guidelines continue to suggest conservative refeeding for that population. So the next big question that I had was, what feeding method do we use to get that nutrition into the patient? US and Canadian institutions prefer meal-based protocols, while NG-based protocols are more common in Europe and Australia. And some institutions use a combination. So with meal-based protocols, supplemental drinks are usually offered if a meal is not finished. And some institutions will place an NG to give the calories that aren't consumed orally, whether by meal or supplemental drink. With NG-based protocols, NGs are usually placed on admission and either provide supplemental nocturnal feeds or comprise all of the initial nutrition, and then the NG feeds will taper off as oral intake is increased. But is there data to support any method over the others based on the parameters we used earlier? So weight gain, length of stay, safety, adherence, patient satisfaction, long-term outcomes. And unfortunately, I would say there's not that much. So let's start by looking at weight gain. So 2002 chart review compared a group of girls who received oral refeeding to a group that received oral refeeding in addition to supplemental nocturnal nasogastric feeds. And you can see that the second group gained almost twice as much. This next study was actually done in a residential facility, and patients were asked to volunteer to get supplemental NG feeds, and that group again gained faster. In this study, there was a comparison of just boys, because there was a suggestion that because boys have higher caloric needs, they may have a harder time achieving those higher caloric needs with just meals. And so they may benefit more from NG refeeding. That was kind of the hypothesis being thrown out. And so the group that received NG feeds in addition to meals, again, gained more weight. This 2007 study was a randomized control trial where patients were randomized to either get only meals or to get meals plus supplemental NG feeds. And then they were admitted for 10 weeks, pretty much regardless. So they didn't look at length of stay, just at weight gain. And they again found faster weight gain in the patient that was getting NG feeds. In 2013, there was a review, literature review done to look at effects of different refeeding methods. And so this did include kind of the above studies as well as several others. And they found overall that with NG refeeding, there's an average weight gain of 8.4 kilos, whereas for oral refeeding, the average weight gain was 6 kilos. But some of the articles did not include length of stay, so they couldn't determine the rate of weight gain. And so it's kind of hard to make too many conclusions from this. We don't know how long these patients were admitted compared to these patients, since they may have just gained more weight because it was over a longer period of time. And then we have a 2013 study where patients, where different cohorts were looked at. So the oral refeeding cohort was generally started on 1,000 to 1,200 calories. And then this was the only study that I saw that where the protocol was to give continuous NG feeds with no oral feeding initially. And so they were prescribed 1,500 to 1,800 calories initially, and they've gained more weight. So a couple of the studies that we just mentioned discuss length of stay. The first two didn't have too much of a difference in the chart literature review that Hart 2013 did. They noted about a 6-day shorter length of stay with refeeding, but a lot of these studies that they looked at did not have comparison groups. So it's hard to make conclusions if you just have different institutions where some are doing NG and some are doing oral without any comparison of what other differences they may be across institutions and protocols. In this study, again, this was the study where one group got meals and the other group got only NG and was not eating anything at the outset. And they noted a shorter length of stay. So it would be easy to conclude from the studies that NG feeding protocols result in faster weight gain and shorter length of stay. However, none of these studies are prescribing the same number of calories with the different methods. In most of these studies, except for Augustino's, both groups are getting meals, and then one group is also getting NG supplemental feeds on top of what they're eating. And so what is actually probably driving the faster weight gain and the shorter length of stay is higher calorie refeeding. They're getting more calories. What these studies do demonstrate, though, is that supplementing with NG feeds is a viable method for achieving higher calorie refeeding. But equally good weight gain has been reported using only higher calorie feeding. So, for example, these two studies are showing, or these studies are showing anywhere from 1 to 2 kilos per week. But we have reviewed some other studies that have shown similar rates of weight gain with just meals. So let's discuss some aspects of adherence and tolerability of different feeding methods. We've reviewed multiple studies that successfully got patients to complete higher calorie refeeding orally, with only a small percentage of patients getting an NG for food refusal. So how are they doing this? This question is of special interest to me, as we recently had a patient on the hospital medicine service with anorexia nervosa who was admitted for several months, and to my knowledge, never ate during the entire time that she was in the that he was in the hospital, and was just fed with NG feeds the entire time. So in 2013, I mentioned a couple of trials that showed that patients are able to consume the prescribed caloric intake with high fidelity, even if it's higher calories. But those studies reported little in the way of strategies for achieving this, aside from stating that meals were supervised. So there is a 2017 study from Boston Children's that said that meal supervisors at their institution received education on meal supervision. They received in-service training opportunities, and then they would encourage patients to eat the food on the tray when necessary. And they actually reported a decreased length of stay after they started supervising all their meals. But they also commented on how labor intensive that process was of kind of training and then supervising all the meals. A 2017 study shared that patients would eat in a group setting at their eating disorder facility, and so that and they would be supervised by licensed psychiatric techs or vocational nurses. The coolest strategy that I encountered was from CHOP, where they train multidisciplinary providers as well as families in principles of family-based therapy, and they stated that nursing staff and parents would use those principles to coach patients to eat by mouth, and 90% of the patients were able to complete their meals by mouth. There are some studies that have talked about incentives and distractions. So a 2016 protocol from Minnesota mentioned meals needed to be completed to go off unit or to engage in physical therapy. And then a 2011 study reported that conversation with staff or music could be helpful distractions while trying to eat. What about adherence to and tolerability of NG feeds? Studies have reported anywhere from 6% of patients removing tubes, which seems very low to me, to over half of patients removing tubes at some point. One study noted that of the patients that removed tubes, they mostly remove them at least 5 times or more. A 2007 study reported that 80% of patients receiving supplemental NG feeds felt like it prevented them from eating during the first week of treatment. Although when they actually looked, the groups that got oral feeds ended up eating the same amount as the one that also got supplemental feeds. So it was just a perception that the patients had that they were able to eat, that they could eat, that they couldn't eat as much. Patients reported a variety of strategies for tampering with NG feeds. And one patient reported in an interview that it was easier to tamper with continuous NG feeds since they were not always supervised around the clock, whereas usually meals were supervised and limited in time. Patient perspectives on the tolerability of NG feedings are complex and sometimes contrasting. They seem to depend on if the NG feeds are, if the NG is placed on an admission or if it's only placed for food refusal. So some comments that were collected from different articles. So some patients found that supplemental NG feeds were acceptable when they were presented as part of a standardized protocol that was uniformly applied, and that placing the NG on admission medicalized the treatment instead of making it seem like punishment for food refusal, and it offered less room for negotiation. Another article reported that patients felt like it reduced the power struggle between the patient and clinicians. One study claimed that it transferred responsibility for weight gain from the patient to the treatment team, which could be helpful during acute medical stabilization. There was a qualitative study consisting of interviews of patients with anorexia nervosa that, where they said that some of them felt like the NG reduced the pressure they perceived in having to eat and temporarily relieve the responsibility for adopting improved eating behaviors. And they also reported that some patients felt the NG was necessary as they lacked the physical or psychological ability to eat. One counterpoint to those potential benefits, though, was that some patients reported becoming attached to the NG tube and feeling reliant on it and were anxious about it ever being removed. On the other hand, though, patients may view the NG as invasive, frightening, or traumatizing. There are concerns that the NG interferes with the fragile alliance between patients and treatment team, that the patient may feel disempowered and embittered towards the treatment team, which may negatively impact future relationships with clinicians. Some felt like it was used as a form of punishment and seen as a strategy for doctors to assert control. Parents sometimes viewed the NG as a last resort for keeping their child alive and not wanting it prior to that. And then there's an ethical question of involuntarily placing an NG on admission, if that's part of the protocol, in a patient who has not yet demonstrated food refusal. And then there can be an emotional toll on staff who have to treat involuntary patients as well. So are there differences in safety? Studies generally report no differences in medical complications, including GI complications or electrical abnormalities requiring medical intervention between meal-based and NG-based cohorts. There are reports of epistaxis and nasal irritation and sinusitis related to the physical tube itself. And there's the potential that since anorexia nervosa patients may be more likely to involuntarily receive an NG tube, that during placement involuntarily, there is a higher likelihood of incorrect placement or trauma from the tube. What about the risk of refeeding syndrome with meals versus NG? There's been a suggestion that continuous feeding may reduce the insulin spikes as compared to getting a bolus from a meal, and therefore reduce the risk of refeeding syndrome, but that was never really tested. It was just a hypothesis. And then what about long-term outcomes? So in the one randomized control trial where patients were randomized to either get oral feeds or oral and supplemental NG feeds, there was no change in relapse at 12 months at the percentage of patients that were able to maintain their weight or in their eating disorder inventory score. So kind of a measure of psychological recovery between the two groups. One other study did look at readmissions at 6 months and their kind of retrospective cohorts and found again, similar rates, not really significant differences. So comparing routes of administration was definitely not as satisfying in terms of kind of the research and conclusions that can be drawn. And unsurprisingly, the clinical report by the AAP in 2021 said that there was insufficient evidence to recommend one approach over the other. Let's skip that. So just to conclude our key points, caloric prescription should start high and advance fast for most patients admitted with anorexia nervosa. Severity of malnutrition is the greatest risk factor for refeeding syndrome, and it's not clear what the best method is there, but most guidelines suggest going conservatively. Electrolytes should be monitored closely for the first week and repleted aggressively, and there's no best route of administration, but that said, protocols improve care and standardized care regardless. So even though there's no one best way, it's probably still beneficial to have a protocol for how patients will be refed. And then I really want to profoundly thank the MMC librarians here who pulled so many articles for me and did a couple of literature reviews for me. They were very responsive, very fast, and I very much appreciate their help. So a bunch of references. And then CME code again, that's my daughter, hopefully developing a healthy relationship with food. Are there any questions or comments?
HADI, thanks for this fantastic grand rounds. I know I took a lot of notes, and I'm looking forward to getting access to your slides and to the video. I think because we're right at the hour, there are a number of questions in the Q&A and in the chat, but I wonder if we could get those to you and have you answer via email, if that would work.
Yeah, that would work. I'm so sorry that I didn't leave enough time for questions.
Oh, no, it was a wonderful presentation with lots of great information that I think we can use here at the Barbara Bush Children's Hospital.
Well, thank you.
Thank you.